Okay, Assalamualaikum and good evening, everyone. So we're back again at CME MedTweetMY. And for tonight, we know that this topic is about basic interpretation of renal profile. And before that, we will actually announce the winner of the contest that we've held for the past few days. And Dr. Rafidah will announce the winners for tonight. And it's exciting because we know there are prizes waiting for them. So without further ado, I would like to invite Dr. Rafidah to present her topic. Thank you.
Okay, thank you so much, Hafsah, for the kind introduction, and thank you so much for everyone who's online today with us. So my topic today is the basic interpretation of renal profile. I think Hafsah mentioned about the contest winners. Actually, I'm going to announce throughout the talk. So just be, just follow the talk, and there will be 5 winners announced in 3 slides. So just watch out for that. So this is the outline of my talk. I'll talk about a little bit of introduction, a little bit about anatomy and physiology, some basic renal tests, urea, creatinine, eGFR, urine. And I would want you to, by the end of the talk, to be able to differentiate between acute kidney injury and chronic kidney disease. And before the end, I will illustrate you with a couple of cases and conclude. And before that, we won't forget to take a picture. So just a disclaimer, this talk will be in English and there will be medical jargons, and the lab measurements used will be in SI, and which is commonly used in Malaysia. So this is the first winner. So I would like to announce the online name of Pretty Dear. Thank you so much for your tweet. It was a very moving tweet. And she is actually an end-stage renal disease patient on dialysis. She shared, this is very moving. I urge everybody to have a look at the tweet. And I believe she is also a very brilliant young university student. I think we all our prayers and our hearts are there for you. And hopefully you'll do the best. Hopefully you can identify yourself in the chat room and we'll reply and give you the prize. Okay, let's go to my talk. I think it's very important to know about renal profile and kidney per se, because it is very prevalent. I would say very prevalent in Malaysia. Chronic kidney disease is in the population around 14.5%. On top of that, we have a lot of non-communicable disease such as diabetes, hypertension as well. And these are risks to kidney disease. So it's very important that we have a basic understanding of the renal profile for everyone, actually, and we know how to interpret it. Just very basic interpretation would be enough. And this topic is not just for clinicians, but it's for all range of healthcare professionals. And I believe patients, families, and the public is also encouraged to have a basic understanding of renal blood test interpretation. The reason why we do blood tests quite regularly is because the kidney patients have very few signs and symptoms early in the disease. So we need to know how to detect the kidney disease, and we need to know how to test and detect abnormalities and early enough for us to correct and give therapy to assess the kidney function. And very important for us to actually measure the disease progression and predict when we need to do things like dialysis and transplantation. And also change the dosing of medication along the line as well. Okay, so before we proceed, I want to show you the renal anatomy. I hope we all know where the kidneys are. It's about 10 centimeters, both sides at the back under your, it's in the loin area. Here is the kidney. It gets the blood supply from the renal artery via the aorta, the main artery of the body. And the venous return will go, it will go into the renal vein and back to the inferior vena cava. And this is the kidney, right and left. And this is the ureter. And this is the bladder, and this is where you pass out your urine. Okay, this is the anatomy of the kidney, where you have the, it'll be a bit more clear here, when you have the cortex, the outer part, and you have the medulla, the inner part. All right, this is the artery just now, and this is the vein, and you have the calyces here. Okay, if you look very closely here, you just take this part. This part, that is something called nephron. This nephron, if you read, each of your kidneys is made up of more about 1 million nephrons. This is called a filtering unit. Yeah, each of these 1 million nephrons has got a glomerulus and has got tubules. Yeah, this is the glomerulus and this is the tubules. Okay, so basically the blood supply is the same there. It's from the renal artery and all the renal vessels inside here. And if you look at what happens is Once your blood supply goes into the glomerulus, all the toxins, the water, it will be filtered into the tubules, right? Into the tubules, and the tubules is also very important to reabsorb things, you know, that you still need in the body and reabsorb water. So whatever it is at the end, it will be producing urine, right? So this is the urine. You'll be producing the urine here at the end, all right? And the urine will drain here, okay, and it will go out through your ureter, through your bladder, and out will be producing the urine. So basically the kidney filters all the toxic that is not necessary, and it will be removed from your body, and it will go into the urine and remove this way. So what is renal function test? I think very importantly, to screen for kidney disease, very basic actually. You need to know your urinalysis, you need to know your urea, your creatinine, your electrolytes. And to assess kidney function, on top of this, the kidney has got two things just now. I mentioned glomerulus and the tubules. Yeah. So for this talk, I'm going to concentrate on these blue statements. Yeah, the glomerular function per se. So I'll be talking to you about how to measure, how to calculate the glomerular filtration rate. Yeah, and also what does urine protein in the urine means? If the glomerular is permeable, the protein will leak out into the urine. So this is not normal actually. So this is a sign of kidney disease. Yeah. So I'm gonna examine these few things, very basic things, I think. Okay. So a nephron, I repeat again, has got a glomerulus, which is here, and it has tubules, all different parts of the tubules, which I'm not going to discuss today, right? So I'm going to concentrate on the glomerulus only, okay? But in essence, the function of the kidney is very, very important. You excrete the urea, you excrete the waste products such as creatinine, uric acid, metabolites. It maintains water balance, excrete sodium, excrete potassium, excrete hydrogen ions, activate vitamin D, produce erythropoietin, and it filtrates, it receives 180 liters per day of water with all sodium chloride, sugar, and amino acids. It filtrates, that means that everything will go through the glomerulus into the tubules, and the tubules really reabsorb around 778.5 liters. So basically you produce urine about 2.5 liters only. So the kidney really works very, very hard. So this is the glomerulus. If you follow my social media accounts, sometimes when I try to translate into Malay, I would say kilang penapis. This is what it is. Yeah, glomerulus is the kilang penapis. So basically, it receives a supply from the artery, afferent arterial, and it goes in. This is where everything is filtered through. This is the penapis. So if you see under histology, this is how it looks like. Yeah, this is very important for you to know how important this is to our kidney function. Okay, that's part of the anatomy and physiology. This is the fun part. This is the next batch of winners. Amal Sobri, she rightfully mentioned the risk factors of CKD and all these chronic diseases. And the other one is by the name of account NAR 2000, talking about how to prevent kidney disease from the young age, seawal usia muda. So ini sangat-sangat penting, jauhi produk suplemen yang tidak perlu diambil. Ini sangat penting. You know, if you know that this is what I've been advocating in the social media. So please also identify yourself in the chat room, and we will reply and we'll get you the gift fairly quickly as well. Well done. Congratulations. Okay, so let's go to the renal function test itself. The urea, the creatinine, eGFR, and urine. Actually, I'm going to talk about 6 things, which includes the sodium and the potassium as well. Okay, so if you look at the blood investigation, most of the hospitals in Malaysia will have, I think most nowadays will have computerized system. All right, and but quite a lot still use paper. Of course, some use paper and computer. But what basic renal investigation is important is actually the urea, creatinine, potassium, sodium, chloride. These are the main ones, yeah. And some labs, like my lab in Putrajaya, it gives out automatic eGFR measurement. And of course, these are the normal ranges. The urea between 1 to 8, creatinine 64 to 122 in our lab, potassium 3.5, 5.0. But I think I would say here there are slight variations between labs. Yeah, some labs gives up potassium up to 5.2, 5.4. The sodium 135, 145, chloride, and the EGFR measurement. So these are the basic investigation that you need to know to understand what renal function or renal profile is all about. Okay, so that was we try to do a word round. So in my hemodialysis unit. Okay, so I'm going to talk about 6 things. The first one is urea. It's very basic actually. What is urea? Yeah, urea is a natural product from nitrogen and protein metabolism. It's found in the urine, and it's actually a very small molecule, very a molecular weight of 60 only. It's uncharged. It's not bound to plasma protein, so it's literally freely filtered by the glomerulus into the tubules. Yeah. So what happens is if you take foods rich in protein, the food will be converted either into essential or non-essential amino acids. It goes to the liver. The liver will form urea, and the urea will be excreted into the urine. Yeah. So this is the same when you eat. Your protein will also interchangeably become your body protein stores, and that will have a lot of metabolism and becomes a waste product. Again, the urea will be passed in the urine. Yeah. So that's urea. And this is when urea is abnormal. There are a few things when urea becomes abnormal. Yeah, it's very simple actually. If you understand the physiology, it basically reflects the balance you have between the production of the urea in the liver and the urea elimination by the kidneys. So basically, if the urea is produced a bit more, or you take a lot of protein, for example, your urea will increase. Yeah, and if the kidney is not really working, or you're not eliminating urea from the kidney as much, hence the urea will be increased. So there is either that, one or the other, or combination of the two. So this is where a lot of people forget. There are also non-renal causes of increased urea in association with a normal kidney function, normal GFR. So it could be physiological when you eat a lot of dietary protein, a lot of protein, and when you're aging, right? Okay, so this is physiological. There is also pathological when you have things like GI hemorrhage, upper GI bleed, because you have associated with urea is associated with increased protein. The blood in the gut is also effectively like a high protein. So because of that, the urea production is increased, and you have increased serum or plasma urea. The other thing that you always encounter, for example, patients in ICU, you have increased protein catabolism. You have major surgery, for example, you have a severe infection where there is an increase of urea synthesis. Yeah. So, and also tissue damage when you have trauma, things like that. So, this is very important for those surgical base when the urea is high. This is probably because of that, even though the kidney function is normal. The other one is quite commonly seen as well when you have low circulatory states like heart failure, dehydration. So the kidney has an adaptive response. So basically, they will be the kidney will be conserving the urea. So the urea will be relatively higher than what it should be, despite the kidney function being normal. And a lot of times you see when patients are given corticosteroids, this is a drug that can cause catabolic state, and it will increase protein breakdown and the urea production as well. So this is actually one of the reasons why the urea could be high. It is a non-renal cause. So it's not only because of the kidney the urea is increased. Okay, so in summary, so I mentioned just now, when a patient has high urea, you really have to look at the reasons why why this is the reason, not only just because of kidney failure, this is because of so many things. So because of that, you have to look at the patient, you have to assess and see why the urea is high, and make a decision on what to do based on the clinical finding. And the other thing is, if you're pregnant, you take low protein diet, you are overhydrated, you have liver disease, your urea will be low because you don't produce as much. Yeah. So this is one of the reasons why the urea could be low as well. Okay. So that's number one, urea. So the other one is creatinine. Okay. Creatinine is actually a breakdown product from creatine phosphate in the muscles. Okay. So it is a nitrogenous organic acid which is generated predominantly in the kidney and the liver. So what happens is kidney again is the main route for creatinine elimination. So when you produce all this predominantly for your muscle, you need to remove it from your body, right? So again, creatinine is slightly bigger than urea, low molecular weight though still. It's again not albumin bound, and it is freely filtered into the glomerulus. Yeah, so it may be influenced by a lot of things which affects your muscle. Yeah, so serum creatinine is mostly used in as a biomarker of the kidney. But however, if you are a clinician, you have to understand creatinine itself has a lot of shortcomings in actually deciding what acute kidney injuries, which I'm going to touch on a bit later. Okay, so that's 1, 2, urea creatinine. Number 3, I think you've heard about this, estimated glomerular filtration rate, EGFR. So basically, if you're a medical student, a lot of times when I was a medical student, which was like forever, you know, like 100 years ago, we used to use Cockcroft gulp, yeah, but this is no more used in nephrology. Yeah, I know that it's lovely to remember the what do you call that, the equation, but it's no more that. Yeah, so basically we are now using MDRD equation or CKD-epi. This is here if you want something complex, but anyway, you don't have to look at this equation. I'm just putting that for the sake of putting it. There is a lot of calculators, a lot of labs that gives you automatic reading. Yeah, so this is used to actually test or measure the level of the kidney function, and also determine the stage of the kidney disease. Yeah, and basically it should be used in chronic kidney disease when you have something chronic. Yeah, so again, we don't use Cockcroft gulp anymore. Please use this either MDRD or CKD-epi. Yeah, okay, for especially the students out there. Okay, so I'm not going to touch about number 4, potassium, because potassium is actually mainly is in the tubules. All these are actually happens in the tubules. What I'm going to say now, if the kidney has failed, you have a tendency of hyperkalemia, means the potassium is high. That could be dangerous. So this is another one of the component of the renal function of the renal profile function test. The other thing I want to just slide through is sodium. Sodium again is freely filtered from the kilang, from the glomerulus, yeah, but it is actively reabsorbed. So towards the end, towards the part at the drain into the ureter, you don't have any more sodium in the kidney. This is one of the reasons why I keep saying to patients with CKD, hypertension, and all that, please cut down your sodium intake, because if not, the kidney will have to work a lot harder. So this is one of the reasons that's why we always advocate low potassium diet and so on and so forth. The last but not least is actually the urine examination. This is a very simple test, but yet a lot of people forget about it. This is very simple. You have to do it almost routinely, I feel, yeah. Urine dipstick, urine FME, whatever you call it, urinalysis is very important. These are the things that you get from the urinalysis. You look at the pH, you look at the presence of blood, whether it's microhematuria, that if you have a red blood cell in the urine, there's RBC inside there. You wonder whether you are having something like glomerulonephritis or what we call it radang buah pinggang, or stones, things like that. Protein is also one of the most important thing that we look at, because it is an indicator of underlying kidney disease. Yeah, so we need to know your protein, urine, whether there's any protein. You're not supposed to leak all this from your glomerulus. If your glomerulus is intact, these things are not supposed to come through. Okay, so the other thing we look at is the glucose, ketone. You have regularly results of that. And if you have a urinary tract infection, there will be nitrates and there will be leukocyte as well. So this is the markers of urinary tract infection. So those are the 6 basic investigations that I want to tell you about for today's lecture. Okay, before that, let me show you the next winners. Okay, this is Mr. Tony. Yes, you joined at the last minute, but I think your thread was really good. So please identify yourself, and rightfully you mentioned that chronic kidney disease is number 1 cause in Malaysia is diabetes. That's for sure. And Anis Hafizah, well done and congratulations, because you mentioned that you have to make buat pemeriksaan kesihatan awal. This is very important, because we want to make sure that we know and pick up the kidney disease early. Because I mentioned earlier on, you cannot pick up without because mainly kidney disease are asymptomatic, tak ada symptom until the end. So this is very important. Okay, so having had all the blood test results, you want to know, what is happening here? Yeah, so it is extreme importance. You have to know what is acute kidney injury and what is chronic kidney disease. This is a completely, well, it is interrelated, but it's two identity which is differentish lah. So okay, acute kidney injury, this is something that happens deteriorate suddenly. Okay, so this is within hours, weeks, hours, days or weeks, hours and basically hours or days. So how do you know whether you have acute kidney injury? So you basically look at the serum creatinine. There will be an increase in that serum creatinine, by various amounts. So basically there are two main classification, Akin and rifle. I'll just put Akin for example. So this is the three stages. Okay, so it depends on your amount of creatinine increase. So like this one, it also has the urine output as well. So if the patient has got increase in creatinine and or reduction in urine output, as this, it will be labeled as acute kidney injury, for example, Akin stage 1, 2, 3. We don't usually use the EGFR for Akin, but for rifle, you look at, you do use the MDRD EGFR. Kata lain lab you ada automatic benda tu. So you look at the changes in EGFR to classify which level of acute kidney injury that is. Okay, so it is very, very important to differentiate between acute, something that happened very quickly, or something chronic that has been happening for more than 3 months. So basically, I just want to note here, for acute kidney injury, sometimes creatinine itself is not enough. So if you read a little bit more about it, a little bit more advanced, there are newer markers that we look at to tell us that somebody is having acute kidney injury and, to treat early and things like that. Okay, let's go to chronic kidney disease. This is a lot of people confused with this because sometimes when you do a blood test in the private lab, it gives you a EGFR, right? Sometimes you're very stressed because the EGFR, for example, says it's 90, right? But if you're well, you're not classified as having CKD actually. Okay, what is the definition of CKD? So this CKD is someone who has either abnormalities in kidney structure or function. Maknanya you have to have a one of these. Urine protein, proteinuria, urine sediment, normal electrolytes, abnormal histology, and structure problems. Or GFR less than 60 ml per minute. Okay, 3 months apart. Okay, so those people, there's so many who actually DM me, PM me, look, this is my blood test, I'm stage 2, stage 1, but that's not right. Don't worry about it. If you're well, you're well. You don't have CKD. Okay, so this is the definition. Once you have CKD, then yes, you look at the staging, right? There's stage 1, 2, 3, 4, and 5. So this is in accordance to the GFR. Okay, so less than 15 is stage 5, less than 4, between 15 to 30 is stage 4, and so on and so forth. So basically, we use EGFR for CKD only if you fulfill these criteria, the 3 months and less than 60 and things like that. Okay, so if you're actually well and you're roughly about 70 ml per minute, I wouldn't worry about it at all. But of course, you need to do regular checkings. We know even from the tweets, we know that diabetic kidney disease is the most common in Malaysia. If you have diabetic kidney disease, you have proteinuria, basically your kidney progress very fast. That we know. That is the reason why we monitor your proteinuria and we monitor renal function tests fairly regularly in diabetic patients and all patients actually. Okay, so basically the approach to diagnosis is actually it's very practical. I always give practical tips. Always find out what the baseline is. What the creatinine was before of a patient. Always correlate with the clinical history and physical examination. Then you find out, is this acute kidney injury, right? Or is this chronic kidney disease? Or is it both? And also look at the other blood investigations and also arrange appropriate investigations to actually support your diagnosis. And find out the reasons why the patients have acute or chronic kidney disease and treat the underlying cause. Okay, let's go to the case 1. Okay, I have a 78-year-old who was admitted with hematemesis, Malinix 2, urea very high, 42, creatinine is normal, sodium 128, low, potassium is 4.3. Okay, so I'll give you a few more investigation. Blood pressure is 140/70. He's tachycardic. Clinical examination is relatively, others are unremarkable. He's got very good urine output. Hemoglobin is obviously 7 because he had upper GI bleed. So what is the diagnosis? Of course, this diagnosis primarily is upper GI bleed. Of course, you need to rule out what's happening inside, or you need an urgent OGD, quite possibly. And of course, hyponatremia is possibly due to hypovolemia. Okay, that's very clear cut. But if this patient, you very well know that, so the baseline creatinine is 50. So if the baseline creatinine is 50 to 98, this is already abnormal because you're already almost 2 times above baseline. So in actual fact, this is AKI. Right? Although the urine output is less than, is okay, but because of the increase in creatinine, more than 101.5 times, is technically you are in AKI stage 1. But then again, whether you have AKI stage 1 or 2, in this situation, you probably won't do anything except for treating the upper GI bleed. Okay? So you've heard about disproportionate urea creatinine. It's not as simple as creatinine 20 times urea. It's not like that. It's you would wish it's like that, but it's not. So basically, it actually in Wikipedia as well. So I was very impressed with Wikipedia. The urea creatinine ratio. Okay, how do you calculate that? Basically, you have that there is so many calculations, medical and all that. I put in the numbers for that patient just now, and obviously the ratio is more than 100. So it corresponds to GI bleed. So if the urea is disproportionately high, obviously something like dehydration, upper GI bleed, heart failure, and all the rest of it is probably the logical reason. Okay, so on top, although the urea is high, the kidney function was actually normal. Okay. All right, case 2. This is a real case actually. A 21-year-old who was brought to the emergency department unconscious. He was running. Okay, I know I'm a marathon runner, but yeah, this guy really ran in the hot sun. I don't do that. So he had heat stroke. On arrival, GCS was 8. He had core temperature of 41 degrees. He had seizures. He had to be intubated for airway protection, and prompt cooling rehydration therapy was all instituted. He had to be intubated, ventilated, and nursed in intensive care. He had worsening organ dysfunction. He had severe rhabdomyolysis. Yeah, his creatinine kinase peaked at about 31,000. He had hepatic dysfunction as well. So he had acute kidney injury stage 3. Okay. So in this case, his presentation, urea and creatinine, the urea was normal. The creatinine was high, very high, well, high, 500 plus. Instead, not the urea is normal because he was having muscle breakdown. So the creatinine will be abnormally high, disproportionately high to the urea as you would have expected. But a good outcome for this patient, he had continuous dialysis for 60 hours close, and he was successfully weaned off dialysis at 2 weeks and extubated at day 24, discharged after slightly over a month and with a normal creatinine. That's good for him. So that's the 2 cases. The case number 3 is actually a constellation of cases. This is the real cases, yeah. So look at this. The urea is 60, creatinine is 3,200, urea is 90, creatinine 4,000, urea 20s, creatinine 1,000. This is something we see almost on a day basis. My record creatinine for a patient was 5,411. Okay, and the patient walked off. She didn't want dialysis. So strong. So the reason why I'm saying that is because if the patient have this really bad blood investigation and they appear relatively well, may can't be that well, but relatively well, which means this is chronic. Yeah. So basically, when you look at the patient clinically, it will be a high blood pressure. It will be pale, he'll be sallow, there will be signs of fluid overload, like JVP raised, heart enlarged, lungs crepitation, abdomen quite possibly have ascites and edema up to the thigh, for example. Yeah. So you look at other parameters as well. Obviously, in chronic end-stage kidney disease, you have anemia, you have low calcium, high phosphate, and of course, this needs urgent investigation, which is the ultrasound of the kidneys, which obviously most of the time is end-stage renal failure. It will be small bilaterally. Okay, case 4. Don't worry, I have 5. Okay, this is a acute kidney injury from traditional medication. This is common again, right? So look at this, yeah, look at the right upper, this one in my arrow here. So this patient has got a baseline of creatinine. This is about a year ago prior to presentation. Creatinine was 253. So he's already have underlying CKD. So now he came in with a 600, having had taken all sorts of product as usual. So then we have a potential differential diagnosis here, whether there is an acute component, which is now AKI stage 2, if you use the AKI criteria of AKI, whether it's just a progression of kidney disease. Yeah, so these are the two things. Yeah, so we need to differentiate that. So basically what happened to this patient, he had progression of kidney disease. There's no way back. Okay, so he quite quickly needed dialysis. Yeah, so basically what I'm saying here is all these products, it's not without problems. Yeah, I give you, this is another example. We've had this, the picture is actually from a publication, but we had a similar case a couple of, I think about 2 years ago. This gentleman had the same creatinine, about 200 plus, yeah. But he was so worried the creatinine, he went to, I don't know what medication or treatment that he had. He was given special diet of, I don't know what it was, and many tablets, you know. And then he came back to us with a creatinine of close to 1,000. We were quite shocked. Of course, we need to do a kidney biopsy. Right, we need to do a kidney biopsy. We need to know what's happening. Is there something else is wrong with the patient? Yeah, so when we did that, we saw oxalate stones. Yeah, oxalate stones here in the tubules. Yeah, and this is, if you see, this is a quite stones. You can actually see it popped out like that. So this is oxalate nephropathy, where you have stones inside your kidneys. Yeah, all from don't know what products that the chap had been taking. Yeah, because the kidney is already chronic. This you have to take it from me. There is a tubular atrophy and dilatation, all the rest of it. It has shown chronicity. This gentleman did not have any renal recovery. He had to be on dialysis and continue to be on dialysis just because he took these products and this special diet. I don't know what it was, and this kidney never got better, and that's it. Yeah. So basically, calcium oxalate stones have been shown to be deposited in the kidney when you have foods rich in oxalate and also high doses of vitamin C. So be careful. Yeah. So the other things that we looked at as well is actually liver injury. So when you have kidney injury, it's a creatinine 1,000 here, and then we look at the liver. When you have 2 organ injury, you wonder, is it something that he's taking? So this lady actually took some product for Kuros or something. Okay, and then obviously had both liver and kidney failure, right? So thankfully the liver did not, the liver got better, but obviously she had to be dialysis dependent because the kidney did not get better, right? So this is very common again that we see in our daily practice. Okay, so the last case, just to illustrate normal renal function, renal blood test does not mean there's nothing wrong with the patient, yeah? So this is a 32-year-old female who had no past medical history. He had progressive ankle swelling for 3 months, normal renal function, urea normal, creatinine normal, sodium, potassium normal, but he has swelling, he has urine FME protein of 4+, okay? Please don't say everything is normal because this is not normal. So basically, you have to clinically see her, examine her, and look hard for signs and symptoms of connective tissue disease because she's a young female. Yeah. So on top of that, you need to do all other investigations as well, and to look for, for blood count, liver function test, to look at the albumin, serum albumin. Okay, connective tissue screening, vasculitic screening, viral screening, and you do urine PCI, urine protein creatinine index, or 24-hour urine protein. So if it's heavy protein, more than a gram, I usually do a renal biopsy to find out what's wrong with the patient. So the diagnosis here is either nephrotic syndrome. Of course, the nephrotic syndrome has its criteria, which is 3 grams of proteinuria. And if it doesn't fulfill that, it's probably non-nephrotic rich proteinuria. Whatever it is, the impression should be underlying glomerular nephritis, which now qualifies possibly, if it stays on for 3 months, being CKD stage 1. Yeah. Okay. So, right. Okay. So this is my final slide. Well, not second last slide. So kidneys play a huge role and very dependent on many factors. And please don't be too upset looking at abnormal renal function tests. And clinical management and interpretation are just not made solely on the blood and the urine test alone. Always take a step back and look at it holistically. Yeah. Always separate the kidney acute injury to the chronic kidney disease. Yeah. Be very vigilant in picking out acute kidney injury because something we can treat. Yeah, and I think basic understanding of the renal profile test really will enhance our good clinical decision making, and also for the public will empower everyone and to discuss together with the healthcare professionals how to make decisions and how to go forward with the blood investigation results that you have. Okay, so with that, I thank you. We will ask you to open your, I think we'll take a picture if you can open your video before the Q&A questions session. Before that, those winners, please identify yourself if you haven't yet in the chat room. But I would like to announce the next CME session, a Valentine's Day session from a good friend of mine, Dr. Shazwan Rizal, which he is going to present on chest pain assessment on the 14th of February, this time next week, yeah, on Sunday. So thank you very much for listening, and back to you, Hafsa or Is, and I'm happy to answer any questions. Oh, we're going to take a picture, right?
Yeah, we're going to take pictures, but before that, I think you might need to unshare your screen so that we can have all the participants view. And I think we have it now, and we can start. So for those of you who don't wish for the photo to be included, maybe you can switch off your video at the moment. But we're going to take a few photos. So Dr. Rafidah, and feel free to take a print screen from each of your laptop, and we can all share after this. Okay, after the sessions has ended, we can all share on our social media. So smile, 1, 2. All right. I think
thank you.
We've given enough time. So now we're actually reaching the Q&A session. I'll hand over to my colleague, Dr. Iskandar, and I'll take over from there. Okay?
Okay, thank you, Dr. Hafsa. Okay. Today, actually, our CME is, I think, the highest participant ever, more than 1K, I think, participant now. Okay, congratulations to Dr. Rafidah for the fantastic lecture. So we go for the first question from Abdul Muiz. I don't know which Muiz is this. So I have a question. When to get tested for urine analysis for any abnormalities of the kidney? This is the first question.
Okay, thank you. Thank you for the question. I think renal urinalysis is part of the renal screening. Yeah. So if you're well, you have no risk factor, quite possibly it's okay, and you're young, for example. So if you have risk factors like family history of patients with kidney disease, you have hypertension, you have diabetes, you have everything, you not only just take urinalysis, but you take the whole renal screening just now, the renal profile, the urine FME. So I wouldn't just do a urinalysis lah. I would potentially do the whole renal screening test and when you have high risk, like the list I mentioned just now.
Okay, the second question from Muiz is what is the physical states of the abnormalities in the urine that can be observed?
Physical state, it's very difficult because you know why? I keep saying if you really pass out blood, okay. So basically urine, if the urine you have hematuria ataupun red urine, of course that's not right, and you actually have the protein in the urine sometimes give bubbles in the toilet bowl, but that's also, it's difficult to say, if you see the bubbles in the toilet bowls, it's difficult to say you have protein in the urine, so you really have to test. And the other thing is if you have urine infection, that the urine is slightly cloudy. So those are the some physical signs lah, but otherwise it's very difficult to have any just to look at it and say that's there's disease there. You really need to go for test.
Dr. Rafidah, am I right to say, because I think this program is catered for medical professionals, but I'm sure out there are a lot of laymen who's joining us. So is it right to say that if you don't have symptoms, it doesn't mean that you don't have kidney problem?
Absolutely. I think that's the reason why we're telling the public that if you have risk, you screen. Yeah, so the risk factors include, if of course, if you are diabetes, hypertension, you definitely have to go for screening lah. That's for sure. But if you have got like overweight, obesity, you have family history of renal disease, you have history of taking regular traditional medication, for example, you have had history of passing stones, those are the people who definitely have to be screened. In fact, if they're well, they really need to be screened to make sure that you can pick up the kidney disease early, because I mentioned just now, as Hafsah put it as well, the kidney disease is very silent until it's very late. So this is very important for you to have a screening earlier.
Okay. Okay, the second person is fallen night. Oh, kalau ada satu kidney ke macam mana, doktor?
Okay, so thank you for terima kasih soalan tu, saya jawab bahasa Melayu lah ya. So kalau satu kidney it's okay, kalau kidney tu normal. Biasanya kita manusia sebenarnya memerlukan tak memerlukan dua kidney, satu saja. Sebab tu anda boleh menjadi penderma buah pinggang, because kalau kidney satu lagi okay, insyaAllah tidak ada masalah untuk anda jadi penderma, tapi kena make sure that kidney satu lagi tu okay lah ya. So basically ada juga entity yang dilahirkan dengan satu kidney. For example, even my own brother was born with one kidney, and his kidney function after 45 years of life is still masih normal. Ya, jadi memang okey, tak ada masalah, as long as you perlu buat pantauan lah, periksa dan jaga diri, make sure that you gaya hidup sihat, tidak ada kencing manis, tidak ada darah tinggi. Sebab kalau you ada penyakit-penyakit tersebut, senanglah untuk affect satu kidney ya. Kalau dua pun affect satu kidney, lagi risiko dia tinggi. Itu je lah. So insyaAllah tak ada masalah kalau jaga baik-baik.
Okay, next question will be from Ami Jalil. How to decide which EGFR formula to use, MDRD or CKD-epi?
Okay, that's a very good question again. So the answer is the MDRD was actually used for it was a prospective. This one it came up from people who has mild renal impairment. So CKD-epi is a bit more. The nephrologists like CKD-epi a bit more, because in MDRD it doesn't really pick up well the ones yang dah advanced CKD tu, the late stage, yeah. Because it was coined with using mild subjects. So if you ask nephrologists, we actually use CKD-epi quite a bit, more than MDRD. But to me, even if the lab has MDRD, that's good enough already. So that would be my answer lah. What do you have MDRD in Kuala Pilah, Iskandar?
No, we have to calculate it manually.
Okay. That's fine. Calculator.
Calculator, yes.
Yeah.
The next question will be from Natasha. I have a question. Between 24-hour urine protein and urine PCR, which one is more accurate for protein quantification? When can we repeat one if need to?
Okay, so the answer is very simple. Of course, it's 24-hour. To me, it's 24-hour urine protein. But you can imagine how difficult that is to do a 24-hour urine protein for the patient. So I tend to just use urine PCI. If I'm like in a doubt, this is how I do. I'm like in a doubt, then I will do a 24. I very, very rarely do a 24-hour urine protein. But because to me, it makes no real difference, because I also see other parameters as well. And it makes it difficult for the patient to do the test. So whether you want to repeat or not, it really depends on the clinical history, clinical findings. Yeah.
Okay, next question in Malay, bahasa Melayu, from Regime. He is like me. Saya bekas ahli bina badan. Sekarang EGFR reading sekitar 50%. Creatinine sekitar 180. Adakah body mass saya yang ada masa ini mempengaruhi bacaan renal sebagaimana BMI manusia tidak terpakai pada saya? Adakah saya ada CKD?
Okay. You bukan bodybuilding kan?
Dulu sebelum lah.
Okay. Okay, so jawapan dia yes, kalau kalau ada muscle mass yang banyak, creatinine mungkin akan tinggi. Tapi to me 180 180 tu agak tinggi jugalah, ya. Agak tinggi juga. Kalau nak tahu betul-betul, dia memang ada cara untuk tahu. You do your nuclear imaging, you do your all this DTP, DMSA, all these things. But I rasa tak perlulah kot kan. So saya rasa saya rasa apa yang Cik boleh buat is just observe ya, maknanya okay, you just repeat again, you tengok berkala, buat ujian berkala nak pastikan benda tu stabil. So definasi CKD atau tidak tu, kalau ikut definasi tu kira dah masuk juga rasanya kan, dah masuk juga CKD.
Betul.
So tapi walau bagaimanapun dia kalau stage dia 2 atau 3, insyaAllah kalau you stabil, you tak ada buat apa-apa, insyaAllah benda tu akan stabil. Jadi jaga diri baik-baik lah. Just pantau berkala sahaja. Don't worry about it.
And again, this is actually to share with the public out there who might be with us this evening. Dia kalau misalnya kata just nak untuk pemahaman lah kan, pemahaman yang basic. Sebenarnya buah pinggang kita ni berfungsi, dia ada kapasiti dia, betul tak? Kalau lebih daripada kapasiti tu, itu yang bekerja lebih keras, sama ada sebab suplemen ataupun ada faktor risiko yang lain, itu yang menyebabkan kerosakan dan kegagalan buah pinggang.
Yeah.
So the next question from Ki Ying Eng. Do we use all the staging system for pregnant women as well? Interesting.
Okay, so pregnant woman, basically what happened is their urea and creatinine a bit on the low side. Yeah. So in pregnant woman, the actual staging is not really correct lah. That's why the indication for dialysis for pregnant woman is a lot lower than a non-pregnant woman. Because even though the urea and creatinine is actually low, it's actually high, it's actually falsely low. It should be higher than what it is. So the indication for dialysis is different. I wouldn't use it for the CKD for pregnant woman. But of course, before pregnancy, if you have CKD, please discuss with your doctors first before getting pregnant lah. So that's the answer. But in pregnancy, I believe I would refer to a nephrologist and make a decision there. Yeah.
Okay. Next one is from Aisha. I want to ask if AKI presentation includes generalized lower back pain.
Generalized lower back pain.
Yes.
AKI, there are multiple reasons for AKI. If a lower back pain, usually not a symptom of AKI. AKI, acute kidney injury, can be caused by various things, like what I mentioned just now, dehydration, projectile bleed, everything, but not usually that. But you might be indirectly causing it, I don't know. Maybe there are some other reasons why you have back pain, so need investigation and clinical examination investigation to decide whether you have that or not.
Okay. The next one from Akmal Anas Muhammad Zamri. In the latest CPG of type 2 diabetes mellitus, the term of CKD is replaced by diabetic kidney disease. Why and how this change is significant for our practice?
Okay, it's just a terminology, my dear. So it's CKD is CKD. What diabetic kidney disease replaces diabetic nephropathy. We don't call diabetic nephropathy anymore. We call it diabetic kidney disease. So you still have CKD secondary to diabetic kidney disease. So yeah, no difference. It's just we like to change terminology. That's all. We're very good at that.
The next question is from Chip. Okay.
Chip,
Yeah,
Chip, tanya lah.
Doctor, how to determine the acute on CKD? This is the situation we don't know the baseline RP before.
So basically this is very difficult. I agree. If you don't have a baseline RP, it makes it really difficult. So that's why we keep telling the Malaysian patients, Malaysian public, please have some baseline RP because it's very difficult otherwise. So what happened is if you have acute on chronic, what you have to do is only wait. Right, because by definition, if the more than 3 months the creatinine doesn't come down, that's chronic already, right? So there wasn't any acute there. So time will tell whether there was acute component that can resolve or not. So this is the problem when Malaysian patients mostly come crash landing at the door when the creatinine is 2,000. We don't know. What the baseline before. So we can only wait and see whether the creatinine comes down to, less than whatever it is in 3 months time. So if the creatinine remains the same after 3 months, that's probably chronic rather than acute. That's the only way.
Okay. From next question from DM. Hi, Dr. Rafidah. What is the outline of treatment for AKI? Do we treat according to the staging or based on patient's clinical condition? And how do we know when to start dialysis?
Okay, this is another lecture on its own, to be honest. So AKI, there are a lot of well, there's difficult AKI in ICU setting. I think he's talking about it, ICU setting. Very difficult to do studies on because patients are multifactorial, but there are evidence that not starting too early. Possibly, when you're reaching close to stage 3 AKIN, kalau AKIN stage 3 only, you possibly can wait till 3 because starting early diagnosis is also not without problems, and it has its own complications as well. So again, this is individualized, case to case basis. It's very difficult to actually put a finger, okay, this number needs dialysis. So yeah, there's no right or wrong answer there.
So next one is from Shira. Salam doctor, how to take a very good care of our kidney? Is there any food that we should ban or avoid?
Fast food? Fast food, the one that you always take is?
I masak biasanya doktor.
Okay. So the only things the only tangible advice that I always give is macam mana tadi soalan bahasa Malaysia, kena gaya hidup sihat. Dan itu sangat penting, ya, sangat-sangat penting. Dia tak ada makanan A, makanan B, tak boleh makan dan sebagainya. So gaya hidup sihat tu maksudnya suku-suku separuh tu kan, dan dikawal makanan, jangan makan banyak makanan segera sebab kalori tinggi, sebab kandungan garam tinggi, itu sebabnya. Jadi jadi gaya hidup sihat, tak ada makanan A, makanan B, tak ada. Tapi nak avoid makanan apa pun, yelah, kita manusia, kita duduk kat Malaysia, makanan semua sedap kan kawan-kawan semua. So kalau nak rasa, makan sikit, cubit je. Macam Is kan nak makan apa tadi? Cubit je. Macam tu. So saya selalu cakap macam tu, makan tu berpada-pada, tapi janganlah tengok aje, nanti kan jadi depressed, sedih pula tak dapat makan, susah juga. So makan sihat, healthy lifestyle. Kalau ada masalah non-communicable disease macam kencing manis, darah tinggi, tolong cek dan pastikan itu penyakit itu terjaga. Jadi jangan, tak ada makanan yang boleh makan atau tak boleh makan lah. Just jaga je lah quantity atau portion, itu yang paling penting.
The next question, I think this one from pharmacist, Tan Yu Ling. Hi Dr. Rafidah. Doctor has mentioned that crop cough gulp not used in nephrology practice. Is this just applied to diagnostic purpose or including determine dosing adjustment to the medication?
Okay. This is a very interesting question. Pharmacist, I always have. I love my pharmacist. Jangan marah. We can argue until the cows come home. Actually, to be honest with you, I think the guideline in pharmacy books generally still using cough gulp. Reason because it's it's been done many years ago, and although we've moved on, the studies will take a lag many years to actually be used. So the dosing of drugs, if you're talking about pharmacies, I'm always a person who, when, and I give you an example is somebody is very ill in ICU, for example, with septicemic shock, no urine, acute kidney injury stage 3, for example. If you look at the cough gulp, it's basically single digit. Okay, I'm not a person to cut down the dose of antibiotics. I don't do that because there's no point treating the kidney or trying to protect the kidney, but the patient dies. So I don't really cut down. Again, case to case basis lah. Case to case basis. But I find the pharmacists are still using cough gulp. We don't. But Putrajaya, for example, we're already using MDRD inside the system already. So I think they're already using MDRD, if I'm not mistaken. So that's fine. Yeah. I think you move away from cough gulp because zaman dulu tu.
Next one from Vivian Chu. Hi Dr. Rafidah. I would like to ask this question. I have encountered several patients having abnormal UACI result in nephrotic range, but urine FME showed protein is negative. Is the UACI result is false positive? What is the next step would be?
Okay, well, I need to see the patient, what the clinical history is all about, really. It's a bit odd to have a urine albumin fairly significant, but urine protein negative. So I would personally, I would look at the clinical history, and personally, I would do a few and then look at the trend. Yeah.
Okay. The next question from Brandon Su. Actually, it's quite a hot question, hot topic.
Oh, yes.
Good evening. Why are so many dangerous direct sales products in the market? Is poor regulation the issue?
Okay, I'm not an enforcer. I wish I am, but I'm not. So this is the problem with enforcing. I know there is guidelines already. You're not supposed to advertise any product. Doesn't matter, like any product. You cannot say it helps kidney. That 20 diseases. You're not supposed to say that. But again, that is already salah dari segi akta already. But the problem is it's rampant. And there's not enough hands, legs, and whatever else to enforce regulations on these people. So what we can do as healthcare professionals, we have to increase our efforts in public education and hope that people make empowered and proper choices in managing their own disease. Yeah, so that's all we can say. I'm not an enforcer. I don't have a machine gun to shoot people, so I can't answer from that point of view. I think it's difficult lah sebab memang ramai yang buat ni. Yeah.
I think another question is from Hasrul Aizad. I think he is also a bodybuilder. Okay. I have a question for a bodybuilder that is taking supplements, specifically protein. How does it affect the kidney in the long term or short term? And should they take it like is there any guideline for it?
I think there's no specific guideline about bodybuilding, whey protein, and so on. But I would suggest do regular checkup. Regular checkup. If there is any sign of kidney disease, please don't take. So any load. Huge load will be it will be a heavy work for anything. The liver, the kidney. But there is no evidence saying that taking large protein straight away the kidney will fail. I don't think I've found that. But there have been some of the products have been reported to cause kidney disease. But I don't know what products that that person is taking. So therefore, I would urge that you go for regular checkups and do regular urine and blood tests. So if you have anything, it will be picked up early and you can actually deal with it early.
Okay. I think next one will be the last question. I think actually there's so many questions. I look at the chat box, it's 40. And then
it's quite scary.
Yeah, it's a lot. But never mind. For the others, after this, you can just ask in the Facebook when we try to answer your question. So the last question is our hot topic also about vitamin C. Okay. From Saishah Zailani. Hello. Recently, there's a hot topic on Twitter regarding vitamin C. The recommended daily intake for vitamin C is 65 to 90 milligram per day. And I read somewhere there's a tolerable upper limit around 2000 milligram. Vitamin C sold in pharmacy is about 500 milligram and even more. Is there any advice on the right way to consume vitamin C for people with or without contraindication or underlying disease?
Okay, I will always stick to my line of statement, which is only saying that the guidelines say you only need 70 to 100 milligram per day. And that can be obtained from your food. So if you talk to any dietitian, they'll be saying that no tablets can replace good balanced diet. So I'm going to stop there and not say anything else. It's again up to your choices. But to me, why do you need to take something that you don't really need? I've not been, I don't know about you, but I've not taken vitamin C all my life. In fact, I had a fruit juice, very nice. Lots of vitamin C there. So why should I take tablets? Yeah. Nicer, this juice is nicer. Strawberry.
Like me, I producing my own vitamin C because some people say I'm a bit jambu, so that's why.
Perasan.
Okay, so I think thank you very much, Dr. Rafidah. I will give the floor back to Dr. Hafsah. Thank you for the question, and for those who just ask in the Facebook. Thank you.
Okay, thank you, Is. And I would like to say a million thanks to Dr. Rafidah for the excellent talk. As always, and it's very clear. And to me, as I said, this program is catered for medical professionals. And I would like to stress again that the basics are really important for all of us in order to have a good understanding of the special the practice needed, the skills needed in the medical specialty and the application in our daily medical practice. One thing I would like to mention is that it's very important for us to interpret whatever blood test, including basic renal profile, in the context of the patient's background, medical history, and a holistic view, a holistic approach, rather than looking at the blood test. We're not treating blood tests; we are treating patients. So make sure that as much as I don't interpret rash by looking at photos, we shouldn't interpret renal profile not in the context of the patient's extensive medical history. And there's, as I said, there's a lot of non-medic participants here. So pesanan dari kami semua untuk menjaga buah pinggang perlu menjaga kesihatan. Prevention is better than cure. Pastikan amalkan pemakanan yang sihat dan gaya hidup yang sihat, bersenam, dan juga ada Dr. Rafidah sebut tadi, pastikan buat saringan berkala. Check your blood pressure, glucose, whether you have a high cholesterol or not, check your heart. Lakukan saringan ini sekurang-kurangnya setiap tahun. Okay? Apa tu, blood pressure, glucose, cholesterol, dan mungkin check juga jantung. Okay? Ada apa lagi yang Dr. Rafidah nak tambah dari segi pesanan kepada orang ramai?
I think you dah sebut dah, Hafsah. Rasanya elok untuk semua menjaga kesihatan buah pinggang sebab kesihatan buah pinggang sangat penting dan statistik dia makin lama makin naik di Malaysia dan risaukan. Jadi harap-harap semua boleh jaga diri baik-baik, dan kalau ada penyakit tu tolong ambil ubat yang hanya doktor berikan, jangan beli ataupun ambil ubat-ubat lain ya. Terima kasih banyak-banyak jaga diri anda baik-baik. Assalamualaikum semua.
Okay, terima kasih Dr. Rafidah. Dan seperti yang kita cakap tadi, buah pinggang ni jika ada masalah, tak semestinya kita akan datang dengan simptom, tak semestinya nampak bermasalah, sampailah ke tahap yang teruk ataupun akhir, barulah ada komplikasi ataupun manifestasi daripada masalah buah pinggang tu. Jadi cegah sebelum kita perlu rawat. Okay. So I would like to wrap up this session. And before that, I would like to share that we have reached maximum capacity of now 500 participants on Zoom, and I heard that we are getting enormous response on Facebook as well. Did I hear correctly that we have over 1,000 viewers?
So I tersempat share pun Hafsah kalau
So we're very glad to hear this because we would welcome everyone. Of course, this is catered for medical professionals, but if you do have suggestions, please feel free to approach us. So I'm the chairperson, but we also have our committee, and we are open to any suggestions or feedback and collaborations as well. Another thing I would like to inform you is about our next session, which is a very interesting topic coming. It's about chest pain assessment, and it will be delivered by our emergency medicine specialist, Dr. Sazwan Rizal. And for those of you who are interested in this topic, chest pain assessment, please join us next week at the same time. And we would be looking forward to seeing you. And thank you so much for your participation in the chat room, in the comment section in YouTube. I hope this would be a regular thing. And I'm excited and I'm really touched by the enormous response that we're getting, and it's all positive, alhamdulillah. Okay, I bid farewell for you guys for tonight and for now. So we're gonna see you guys next weekend at the same time, 8:30 p.m. Malaysian time. So goodbye and assalamualaikum.